I Hate Politics is a podcast about a human activity we love to hate. I'm Sunil Dasgupta. The 2026 Maryland General Assembly session ended Monday, April 13th, and we will be following up with different legislators and advocates to understand the different policy areas. First up, healthcare. The new Speaker of the Maryland House of Delegates, Jocelyn Pena Melnick, was on the show at the start of the session, laying out her vision, and one big part of that was her decision to bifurcate the Health and Government Operations Committee into a Health Committee and a Government Operations and Elections Committee. She then appointed Delegate Heather Bagnall from Anne Arundel County to chair the Health Committee. I talked to Chair Bagnall about the very first session for her committee and her term as chair. Stay with us.
What's the matter? You seem so surprised, glancing in the morning paper tonight. Seems that the French can capitalize, not the execution of a spy. During General didn't die. Watch his family cry. Watch his family cry.
I Hate Politics is a podcast about our neighborhoods, workplaces, schools and streets, and our local governments as they function in diverse and democratic societies. This means our politics are messy, dirty, sometimes corrupt, with often self-serving politicians. But no matter how much we may hate politics, we are never exempt from it, even when we refuse to participate. In fact, the purpose of politics is to keep society functioning precisely when we don't agree with each other, like now. Music for this episode comes from Silver Spring rock musician J.D. Brayton, who goes by the stage name Mr. Tree Frog. The two songs we play in this episode are Halo and Troubled Sleep. You can find his music on Bandcamp. Heather Bagnall, welcome to I Hate Politics.
Thank you so much. Thanks for having me.
Congratulations on finishing up your first year as chair of the newly formed Health Committee in the Maryland House of Delegates.
Thank you.
317 bills. How did it go? What are the highlights?
We had some really great wins this session. I think we got the Public Health Reform Act across the finish line at the very like literally the 11th hour. And that is building on the work of our Commission on Public Health. They made a series of recommendations. We really focused on workforce development and on the coordination between our local health authorities and our state Department of Health so that we could better utilize resources and really make sure that we are advancing population health in every part of the state. We did a lot of really good work for pediatric overstays. For many, many years, we have had this challenge of adolescent populations that are in hospitals. They're there for behavioral health needs, for mental health needs. Their needs aren't really being met by the hospitals. We had kids that were languishing in the hospitals for sometimes days, weeks, even months at a time, and also in unlicensed settings, in hotels and offices. And we had a very tragic outcome last year. During the session last year, we created a stakeholders group that made recommendations. We are no longer utilizing unlicensed settings. We have a path to no longer utilizing hospitals for overstay. And we also...
So where are they going to go?
We have a partnership between DHS and MDH and the hospitals to identify appropriate locations, whether it's a residential treatment facility or whether it's a community and home-based services, because we do have community and home-based services that we've been ramping up. More than anything, it was about the coordination and also about reducing some of the administrative burden and clarifying that like local care teams can already be looking for appropriate placement, even while we're going through these other processes.
Where are the beds?
The issue isn't always the beds. The issue is the appropriate staff for the acuity level. That's where that coordination becomes really important.
So how are you going to meet the staffing needs?
One is those community and home-based services, adolescents who don't need to be in a residential setting can go home. We also put money in the budget for workforce development and for transitioning additional beds to meet behavioral health needs. We also did some work on what's called voluntary placement agreements, and these are for families that have great need. The way these voluntary placement agreements have worked in the past is that the language said you had to exhaust all other resources. Well, that's a very problematic term because it makes it sound like if you have not found every resource and determined that you couldn't utilize those, then you were just having to leave your kid in the hospital. So we clarified that you don't have to exhaust every resource. And then we're also bringing online this month, I think starting next week, is our crisis bed registry.
One hand, we are expanding home-based care, community treatment. And on the other hand, in the developmental disability side, we've actually cut back.
I would argue against that, actually. There's been a lot of talk about how we're pulling back on self-direction. We inherited a lot of issues with self-direction. When it was first rolled out, there was not a lot of clarity on what self-direction actually was. There was a misunderstanding that self-direction was a different menu of services. And it's really not. It's really about who is the employer. It's a different pathway to the same services. Now, there were a lot of mistakes made in the previous administration with the launch of self-direction, and also making sure that the program was sustainable and that we weren't running afoul of federal law. We were within 18% of losing our federal match dollars. That would end all services for the 19,000 families that we're serving.
I imagine the federal match is a very big problem that you had to solve. The issue that I think you will continue to face is backlash from families that were engaged in doing this. Even the provider care in that space, the providers are upset.
I absolutely agree with that. I also think that there are a lot of families that are very scared. These are very, very challenging experiences. And we also are looking at the challenge of HR1, which is going to require us to redeterminations at a greater rate than we've ever had to do before. What I think is that a lot of families are not going to see the adverse impact that they're anticipating.
When you say community and home-based services,
that's the waiver. That's the specific waiver under which these resources are provided. Maryland has a lot of waivers. We have a lot of Medicaid waivers, which actually became advantageous during this administration, because when we were seeing some of our federal funding attacked, some of us raised our hands and said, like, every waiver is a federal contract. So we should not just give up. We should say, no, these are federal contracts. We should ask for the completion of a contract. Our Attorney General was fairly successful in making that argument and ensuring that we didn't lose federal dollars without cause.
Anything else in the Public Health Reform Act that you want to highlight?
Well, we're looking at creating a workforce fund, and we're also looking at how we can make sure that it aligns with the AHEAD model, which is our hospital system. You know, Maryland is very unique in that we have a global budget. We have a hospital system that's all nonprofit hospitals that coordinate, and they share that charity care, that uncompensated care, which keeps our hospitals stable. It also means that we don't have hospitals that have to consolidate. It's why we're able to serve our rural populations.
I'm going to stop you for just a second because these are so many acronyms right now. That I think I need to just lay it out a little bit.
Sure.
So Maryland has had a long-standing relationship with the Center for Medicare and Medicaid Services since 1976, wherein the federal government pays a certain amount for Medicare services in the state that is higher than it would pay elsewhere. And that extra money goes as a cross subsidy, in effect, to reduce hospital care costs and therefore keep our health insurance premiums low. So it bends the curve on the health insurance premiums using what is called an all-payer model, where in a hospital, anybody that goes to the hospital pays the same amount, no matter whether they're using Medicare, Medicaid, or private insurance. Now, the federal government last year in October, November, they decided that they don't want to continue this model. Now, Maryland has to figure out what it is to do now that the state cannot negotiate with the hospitals on behalf of Medicare, which means that they don't know how much more or less Medicare will pay. And that may affect health care premiums.
That's exactly right. The Centers for Medicare and Medicaid under the new administration, under the Trump administration, said, we want to continue forward with AHEAD. We're no longer going to continue total cost of care. We're actually going to terminate that contract a year early, but we're going to advance into AHEAD. But it's no longer health equity, it's health efficiency. We have to show cost savings by being more efficient, getting our ED wait times down, getting into the communities, reducing health disparities. But the more efficient you become, the harder it is to find places to save money. And so the uncertainty that we have now is that because we can't set the rates for Medicare, we now have to figure out, okay, well, how do we balance with Medicaid, which again, we can only set to a certain level, and then with private insurance, which is never a place where we've been. And so the uncertainty comes in, okay, well, what does that do with our Medicaid budget? And what does that do to our insurance premiums?
How are you thinking about this problem?
Well, it's the thing that keeps us up at night. I'll be very honest. In Maryland, we have done a lot of really innovative things to keep our healthcare premiums down. And of course, we only control a certain, portion of the market. But the state has done things like the reinsurance program, where we were able to take that money and provide subsidies for our young adults to get them into the insurance market, which actually widened the pool of healthy insured and got them in earlier and got them in, but even before they had families. And so then their families were under insurance. We have some of the largest amount of mandated services, and yet we still have some of the lowest premiums in the country. And a lot of this is just constant negotiation, because we're still able to work with the hospitals. We just can't set those rates. But it is a constant conversation, because we don't want to see what's happened in other states. And it's important to keep the hospitals at the table, because CMS also sort of gave them this off ramp and said, hey, if you don't like it, you can walk away. In a year, you can walk away from this contract. Which is just a very wild idea. There may be some systems that thought they would do okay with deregulating. But when you look at what's happening in other states where their hospital systems are consolidating, their hospitals are closing, their health systems
Virginia
they are collapsing under the weight of this. Maryland has been able to hold strong and hold our systems together. And unfortunately, this is not the kind of thing we can sort of legislate our way out of. The hardest work is keeping everybody at the table and making sure that what you did continues to be implemented. This is that moment. This is that moment where it's a cooperative effort. It is relationship building. And there's a certain amount of trust. And I will say, to their credit, the hospitals signed those contracts knowing that we were all taking on the same level of uncertainty. And I have to applaud our health secretary, who I think worked really hard to get us a contract. And she comes from CMS. You know, she came from, previously had worked for Centers for Medicare and Medicaid under the Biden administration, and the hospitals for staying at the table through some really, really tough negotiations.
If the Medicare reimbursement number from next year falls below what hospitals used to get,
I can't answer that question because we can only do what we can do, and we can only control what we can control. What we can control is how we continue to approach these negotiations. So I'm not going to get out ahead of the Department of Health. I'm not going to get ahead of CMS. What I will say is that we have been as strategic as we could be, and we have put as many protections in place, and we have gone to bat for those dollars and for these programs, because we don't want to see anyone left behind.
One of the things on which Maryland actually has not done well, and something that you mentioned, are the emergency room wait times.
One of the big challenges that the hospitals keep identifying over and over and over is that they have the staff in terms of providers, but then they don't have the throughput staff. They don't have the technicians. They don't have the subacute care so that they can discharge somebody, or they are in need of a long-term facility because they're elderly population. Not only did we have legislation on the ER wait times, but we also passed the Safe Staffing Act, I think this is year 3 or 4, which actually brings those members of the care teams from the hospitals to the table, working on these throughput plans, working on the plans for what adequate staffing at any given time would look like. We also have had a comprehensive policy on assisted living facilities and nursing homes. And one of the challenges we've had is having a place for our elderly populations to go. A lot of people want to age in place, but we also, a lot of people need that additional care. And we haven't had the level of oversight that we would like. And one of the things that we learned through this process was that the federal regulations for nursing homes and assisted living facilities really speak to the facility, not to the standard of care. So they are doing inspections based on the requirements of Medicare. The requirements are not for the standard of care. So we actually had to put standard of care into our state law to make sure that they had the enforcement authority to go after these inadequate providers. I would love to talk a little bit about because this year we created a maternal, infant, and child health subcommittee, because Maryland doesn't have the health outcomes for maternal mortality and morbidity that we would like to see.
How bad are we?
We were a D. We are now a C.
Is this across the board or mainly in minority groups?
Well, this is across the board. When we look at minority groups, it's much worse. One of the big challenges is that that Black women are often not taken seriously with their concerns when they raise concerns with their provider.
Are these numbers worse for Black families than for Latino families?
Yes. Yes.
Hmm. Is our workforce representative?
Not yet. And that's part of it. One of the bills that I had and the speaker had and my senator had and I think a lot of us were talking about was on the other side of this, uh, perimenopause and menopause, which I don't know if you've noticed, but there's suddenly been an explosion of talk around perimenopause and menopause. And I think that's in large part because so many of us went sort of slamming into menopause and looked around and said, what the heck? Like, why is there nothing? Why is there no help? And the reason there's no help is because 20 years ago, there was a very bad study, a very flawed study that said, HRT was dangerous. We shouldn't talk about it. We shouldn't prescribe it. The feds put a black box around it. And for 20 years, clinicians were not taught anything about menopause and perimenopause management. Women were provided no education, no guidance, no help. Now the feds have recognized that was an incredibly flawed study, mostly because it was women who were postmenopausal that were being studied. So HRT wasn't particularly effective because the window where it would have been effective was already passed.
The complaint that I've also heard, and particularly from the medical council, is about the outcomes with physician assistants.
I haven't heard that. I know that there have been some, there are every session there are discussions on expanding scope of practice or expanding who is part of those care teams, right? Or who can practice independently and who has to practice like under supervision. As a legislator, our role is really defining, what is in statute, to the degree of like scope of practice, whether they can whether they can practice without supervision, whether they can practice with supervision or under delegation. But then when we also talk about oversight, there are a couple other entities that are responsible for oversight. And the most important one is actually the patient. And I think that's the one who gets so often lost in translation. People forget that a patient is also a health provider. They're a provider of their own health. They're also oversight of their own providers.
There is such a power asymmetry in a doctor's office.
It absolutely is.
It's very difficult to imagine a patient being more vocal in that condition.
Well, and there's some things that we have done, legislatively, and some things that we've done through regulation. But the patient bill of rights was a big one in the hospitals, making sure that it was posted, making sure that people had access to it upon request. Plain language, where anything that is provided to a patient has to be provided in the plain language of their preferred language. To the extent practicable, and things like training for confirmation training. That's a big one. Is not just disseminating information, but getting confirmation that the person has understood what is being conveyed to them.
One last shot at picking the two things you want to talk about.
I can talk about one bill that, again, is so under the radar because it codifies the federal requirements around mental health and substance use disorder parity. So it ensures that we have to have network adequacy, that people have to have access to behavioral health providers, substance use disorder providers, to the same level that they would to somatic care. And it was in the Affordable Care Act, but this current administration has not been enforcing parity, and they're talking about walking it back. So if they walk it back, it will still remain the law in Maryland. And that's a big deal.
What about the healthcare subsidy
So
in the marketplace?
the subsidy is a challenge. So right now we have covered the subsidy for 2 years. We were able to take money from our reinsurance program, which means that we can't subsidize to the degree that we did previously to get people, young people into the market. But it allowed us to subsidize our existing market for 2 years. But at 2 years, the funding runs out, and then we're going to have to figure out something else.
The Prescription Drug Affordability Board just announced upper payment limits for Jardiance.
Yes.
They were looking at Farxiga as well, but somehow Farxiga didn't make it. Do you understand why?
I don't know exactly where the decisions came from, but that's just the first drug that they're setting an upper payment limit for. I understand that Ozempic is already in the pipeline.
It is.
And there are other drugs behind them as well. And I think part of it with Jardians was also that there was a federal effort that was being taken for Medicare. So we were able to look at Medicaid and also at the individual market. So that sort of expedited that decision process. But it's a huge deal for the state of Maryland. It's a huge deal for our insured folks in the state, and hopefully it will be a huge deal nationwide, because we were the first state to create a prescription drug affordability board, but multiple states have modeled what we've done here in Maryland, which should actually give us all greater bargaining power.
Right. So have you thought of a interstate compact between, like, I think there are 4 states now that have it. So have something like a most favored nation part of the law, which says that if you give it to Washington state, you must also give it to Maryland. And similarly, if you give it to Maryland, you must do it in Washington state.
I don't know that we've thought about that, but I'm writing it down in my handy dandy notebook.
Heather Bagnall, thank you for taking the time. Much appreciated.
Thank you so much. And I could talk with you all night. I love this health policy. It is the honor of my life.
That's all for this episode of I Hate Politics, where we aim to stem the decline in local news by working with community voices. Don't forget to tune in to our Tuesday morning news analysis. I Hate Politics is produced by me, Sunil Dasgupta. Music for this episode comes from Silver Spring rock musician J.D. Brayton, who goes by the stage name Mr. Tree Frog. The 2 songs we play in this episode are Halo and Troubled Sleep. You can find his music on Bandcamp. If you want to share your music on the show or know someone else who might want to, please email producer@ihbpod.org. I hope you'll subscribe and share the podcast as we bring you stories about politics close to you and to your home. See you next time.
Thank you.